Welcome to the deep dive. Today we're looking at hemorrhoids. It's incredibly common. Something like half of adults over 30 get symptoms.
That's right, but it's definitely something people don't often talk about openly.
Exactly. So consider this your kind of focused guide. We're aiming for effective revision here.
We've basically pulled the key info from our notes. A comprehensive overview, but, digestible.
Yeah, so whether you're prepping for the MSRA or maybe you just want to understand it better, we're hoping to cut through the noise.
Our mission really is to get the crucial stuff out there.
What they are, causes, risks, how they work, what else it could be.
Who gets them, how they present, diagnosis, treatment, the whole picture.
Prognosis, complications too. And that statistic, about half of adults over 30, really shows how relevant this is. Okay, let's get into it.
Let's start right at the beginning. The definition. Hemorrhoids are essentially swollen, inflamed blood vessels. Location, rectum or anus.
But the tissue itself isn't the problem initially, is it? It's normal.
Absolutely. Hemorrhoidal tissue is completely normal, even essential. It actually helps with continence, sealing the canal.
Oh.
It only becomes an issue, becomes hemorrhoids in the problematic sense when it gets enlarged and starts causing symptoms.
Right. And there's a key difference between internal and external ones, based on location.
Exactly. It all hinges on the dentate line. That's the anatomical landmark.
Okay.
Internal hemorrhoids. They start above the dentate line, inside the rectum, external ones. Below it, under the skin, around the anus, the anoderm.
And that location difference matters for symptoms, right? Because of nerves.
Precisely.
Right.
The anoderm below the line is rich in nerve endings, making external ones potentially more painful. Internal ones above the line, often less so, at least initially.
Got it. And those internal ones, they have grades, like a IIV scale.
Yes, based on prolapse, how much they push out. Grade 1, no prolapse, they just bleed, maybe.
Right.
Grade 2, they prolapse when you strain, like for a bowel movement, but then they go back on their own, spontaneously reduce. Grade 3, they prolapse on straining, but you have to manually push them back in.
Needs a push.
Needs a push. And grade 3, they're permanently prolapsed. They just stay out and can't be pushed back.
That's a really clear progression. Grade I inside, 2 plops out, goes back, 3 needs a push, 4 stays out. Simple way to remember.
Exactly. And external ones.
External.
Well, they're under that sensitive anoderm, so they can cause pain, itching. You can usually see them as lumps around the anus.
And it's possible to have both types at the same time?
Oh, absolutely. It's quite common, actually.
Okay, so that's the what. Now, the why. What actually causes these vessels to swell up?
Well, the notes say the exact cause is still a bit uncertain.
Really?
But the main contributing factors seem pretty clear. It's increased pressure down there in the rectal area.
Uh-huh.
And also a weakening of the connective tissue in the anal canal, the stuff that's supposed to support those blood vessels.
And I guess straining during bowel movements fits right into that pressure idea.
Definitely. That's a key one. Chronic straining really puts pressure on those rectal veins time after time.
Makes total sense. So who's most at risk? What factors make someone more susceptible?
We can sort of group them. Things that increase susceptibility. Well, constipation is a big one. Chronic diarrhea, too.
Both ends of the spectrum. Interesting.
Yeah, both put stress on the area. Pregnancy is another major risk factor, hormones, plus the physical pressure.
Right.
Then there's obesity, prolonged periods of sitting or standing, even just getting older as tissues naturally weaken a bit.
So lifestyle, life stages, age.
Yeah.
Quite a mix. Any others?
Yeah. Prolonged straining on the toilet itself, not just constipation. Things that increase abdominal pressure generally, like a chronic cough or lots of heavy lifting.
Ah.
And then things like spinal cord injury, rectal injury, IBD, inflammatory bowel disease, and sometimes there's a hereditary component too. Family history.
So it's often a combination, not just one trigger.
Usually, yes.
Okay, let's dig into the pathophysiology a bit more. The how, what's the mechanism?
So the core mechanism, as we've kind of said, is that elevated pressure in the rectal and anal veins.
Right.
This increased pressure causes them to stretch, swell up, get inflamed, distension, basically.
And that happens differently for internal versus external.
Well, the location is different internal within the rectum, external under the skin around the anus. But the underlying process of pressure leading to engorgement and swelling is similar for both. The vessel walls weaken under the strain.
That clarifies it nicely. Now, differential diagnosis. This seems crucial. If someone comes in with symptoms, what else could it be?
Absolutely critical. You don't want to miss something serious. The notes list several key mimics. Anal fissures, those little tears.
Painful, I imagine.
Can be, yes. Rectal prolapse, where the rectum itself pushes out. anal abscess or fistula infections near the anus, and, importantly, colorectal cancer. Always need to rule that out.
Definitely. Are there other, maybe slightly less common things to keep on the list?
Yes, the list also includes anal carcinoma, which is different from colorectal cancer, other types of IBD like Crohn's or ulcerative colitis, adenomatous polyps,
Okay.
condylomata acuminata, that's anal warts, anorectal abscesses again, and just general causes of pruritus ani, that anal itching. Could be threadworms, contact dermatitis.
Wow, quite a range. Really highlights why you need a proper evaluation.
Definitely not something to just self-diagnose based on symptoms alone.
Okay, so how widespread is this? What's the epidemiology look like in the UK?
It's really common. As we mentioned, around 50% of adults over 30 report having symptoms at some point.
Half the population over 30, that's huge.
It is. The annual incidence new cases diagnosed each year in the UK is around 29,000, though there's a bit of variation in studies.
Oh,
Yeah, prevalence rates reported in the UK range from maybe 13% up to 36%. An international survey found about 11% in adults.
a lot of difference.
Well, part of it might be how data is collected. Self-reporting can be tricky, and people might think they have hemorrhoids when it's actually something else causing similar symptoms. So the figures might be slightly overestimated.
Right, that makes sense. Misattribution of symptoms. Okay, clinical features. How do they typically show up? What are the key signs and symptoms?
The classic one is bright red rectal bleeding, usually during or right after a bowel movement, often noticed on the toilet paper or in the bowl.
Painless bleeding is common, you mentioned.
Yes, painless rectal bleeding is actually the most common symptom overall. People might also have itching, irritation, or just general discomfort around the anus.
And pain.
Pain can happen, especially with external hemorrhoids, and you might feel or see a swelling or lump there too. Pain is often a sign of a thrombosed hemorrhoid, though.
Thrombose meaning a clot.
Exactly. A blood clot forms inside, causing sudden, often quite severe pain.
Okay, what about other things, like itching?
Pruritus ani, the itching, is definitely common, and sometimes, with the more advanced internal ones, grade 3 or FE, people might experience soiling.
Leakage.
Yeah, involuntary leakage of stool because the prolapse interferes with the anal seal.
And what would a clinician actually see during an examination?
Well, on external inspection, if they're internal and not prolapsed, you might not see anything obvious.
Right.
You might see signs of irritation from chronic mucus discharge, perhaps. If you ask the patient to strain, sometimes internal ones become visible at the anal verge. They look like bluish, bulging vessels.
And thrombosed ones.
A thrombosed external hemorrhoid is usually pretty obvious. A distinct purple, swollen, tender lump right near the anus.
And the digital rectal exam, even if you can't feel internal ones.
Still absolutely essential. You might not feel uncomplicated internal hemorrhoids, but the DRE is crucial for feeling for other things, lumps, tenderness, assessing sphincter tone, and generally ruling out other pathology in the anal canal and lower rectum.
Can't skip the DRE then.
What?
So after the history and exam, what investigations might follow?
Initial steps are usually that visual inspection and the DRE we just discussed. To get a better look inside, especially for internal hemorrhoids, anoscopy is common.
That's the short scope.
Yes, a short, rigid scope. Or flexible sigmoidoscopy, which uses a longer, flexible camera to see the lower part of the colon.
Okay.
Stool analysis might be done to check for other causes of bleeding. Proctoscopy, another type of scope exam, can also give a good view of the rectum and anus.
And if cancer is suspected,
Then you absolutely follow the NICE guidelines. That usually means further investigation. Often a full colonoscopy is needed.
right. Any other specific tests?
In some complex cases, anorectal physiology studies or endoanal ultrasound might be used, but that's less routine. And a full blood count, an FBC, is often checked.
Why the FBC?
Primarily to check for anemia in case there's been chronic blood loss. Also might show signs of infection, though that's less common with uncomplicated hemorrhoids.
Okay, quite thorough. Now, management. What can actually be done?
It usually starts conservative. Lifestyle changes are key.
Like diet.
Absolutely. Increasing dietary fiber, fruits, vegetables, whole grains, and drinking plenty of fluids. This helps soften stools and reduce straining. Regular exercise helps too.
Makes sense. What about immediate symptom relief?
Topical treatments, creams, ointments, suppositories can help manage itching and discomfort. Many are available over the counter.
And if lifestyle changes aren't enough for internal ones?
For persistent grade IN2 internal hemorrhoids, outpatient procedures are often very effective. Rubber band ligation is common.
Banding them off.
Pretty much. A small elastic band cuts off the blood supply and the hemorrhoid eventually shrinks and falls off. Sclerotherapy is another option, injecting a solution to shrink it.
Okay, and for more severe cases, surgery.
Yes. If things are more severe or don't respond to other treatments, surgery might be needed. Options include hemorrhoidectomy,
Removing them entirely.
yes, surgical removal, or stapled hemorrhoidopexy, which sort of lifts the prolapsed tissue back up and cuts the blood supply, or hemorrhoidal artery ligation, finding and tying off the arteries feeding the hemorrhoids.
That sounds more targeted.
It's often a minimally invasive approach, yes.
What about those really painful thrombosed external ones?
Ah, yes. Acute thrombosis. Management focuses on pain relief first. Oral painkillers like paracetamol, ice packs, stool softeners to avoid straining.
Can they be removed?
If a pain is really severe and it's caught early, within about 72 hours, excision cutting out the clot and vessel can give very rapid relief.
And if it's been longer than 72 hours?
Then usually conservative management is preferred, as the pain often starts to improve on its own by then, and surgery might not offer as much benefit compared to the recovery. Symptoms typically resolve over 10-14 days.
Right. So going back to prevention and general management, avoiding constipation is huge.
Paramount. Fluids, fiber. If needed, bulb-forming laxatives like psyllium or ispagula husk can be helpful.
And pain relief.
Simple analgesia like paracetamol is usually best. Avoid codeine if possible, as it can cause constipation.
Good point.
Short-term topical anesthetics or corticosteroids can sometimes be used for flare-ups of pain and inflammation. And just good perianal hygiene, keeping the area clean and dry, is always important.
Okay, so just quickly recap the non-surgical options again, besides banding.
Sure. For internal hemorrhoids, especially lower grades, besides rubber band ligation, there's infrared coagulation or photocoagulation using heat, injection sclerotherapy, and techniques using bipolar diathermy or direct current electrotherapy, all aim to shrink or obliterate the hemorrhoidal tissue.
Got it. And the main surgical routes.
Traditional hemorrhoidectomy, circular stapled hemorrhoidopexy, and hemorrhoidal artery ligation. Those are the main ones.
Okay, clear. So what's the overall outlook, the prognosis?
Generally good for most people. The majority manage well with conservative measures, lifestyle changes, maybe outpatient treatments like banding.
That's reassuring.
It is. But recurrence can happen, especially if those underlying risk factors like constipation or straining continue.
Does everyone eventually need surgery?
No, definitely not. Estimates suggest maybe around 10% might eventually need surgery for persistent or severe symptoms.
And pregnancy-related ones.
They often improve significantly or even resolve completely after delivery.
Ah, good to know. So prevention is key for long-term outlook.
Absolutely. High-fiber diet, good hydration, avoiding straining, those are the cornerstones of prevention and managing recurrence risk.
Makes sense. But are there potential complications we should be aware of if things get worse or aren't treated?
Yes, complications can occur, although thankfully not in most cases. Thrombosis of external hemorrhoids causing that acute pain is probably the most common complication.
Right.
Chronic blood loss, even if it's small amounts each time, can eventually lead to iron deficiency anemia. That's why the FBC is important.
Okay, anything more serious?
Rarely, internal hemorrhoids can become strangulated. This happens if they prolapse severely and the blood supply gets cut off. That can lead to tissue death, ischemia, even gangrene. But that's uncommon.
That sounds serious.
It is, but rare. Other potential issues include skin tags forming after hemorrhoids resolve or are treated, ischemia, thrombosis, gangrene and strangulated ones as mentioned. Very rarely, perianal sepsis, a nasty infection. Severe bleeding causing significant anemia is possible, and sometimes thrombosed external ones can ulcerate.
Okay, so a range of potential issues, mostly related to thrombosis, bleeding, or rarely strangulation and infection.
That sums it up well.
This has been incredibly thorough. We've gone from the basic definition right through to treatment and those potential complications. Really useful overview.
Glad it was helpful. It's such a common issue. Understanding it clearly is important for healthcare professionals and, well, anyone experiencing symptoms, really.
Absolutely. So for you listening, we really hope this deep dive has given you a clear, high-yield picture of hemorrhoids. Good for revision or just general knowledge.
Definitely.
And maybe a final thought to leave you with. Just consider how much those lifestyle factors really impact both getting hemorrhoids and managing them. What small changes could potentially make a big difference for someone?
That's a great point. Prevention and management often start there.
And if you are prepping for the MSRA, don't forget passthemsra.com and freemsra.com. Loads of great resources there.
Definitely check those out.
Thanks so much for joining us for this deep dive.